This is Dr. James Marion once again for our third Thursday live from the Susan and Leonard Feinstein Inflammatory Bowel Disease Center here at Mount Sinai Medical Center in New York City. I'd like to welcome you yet again. And today we have a very special guest, a terrific colleague, one of my favorite colleagues here at Mount Sinai, Dr. Pascal White. Welcome, Pascal.
Hi, thank you so much for having me.
And
you're my colleague too, just for that.
Oh, stop. Pascal, that can't be true. But Pascal is an assistant professor here in the Department of Medicine, Division of Gastroenterology. But most importantly, and I think probably the most amazing thing that Pascal does is Pascal has turned our gastroenterology clinic as our director of the gastroenterology clinic into a truly amazing place, not just for educating residents and fellows, but for serving patients who were otherwise not getting served the way they needed to be served. So Pascal doesn't just talk the talk here, Pascal is walking the walk, and I have profound admiration for the work that you're doing in the GI clinic, and also enlisting all of us to remember that is really part of our mission here at Sinai. So I am forever grateful for that. Gosh, I could go through all of your resume here. You know, there's some NYU, you were chief resident. All that's true, but you're just amazing. And it's great having you around, and you really bring something to the division that I like. It's not just enthusiasm, but real passion. A lot of the work that Pascal has done on disparities in access to medication for people of color, and for people of lower economic class has been, I think, really just eye-opening for all of us. So Pascal, welcome.
Thank you, thank you. Thank you so much.
One of Pascal's most important leadership areas where she's really shown national leadership is colon cancer surveillance, access to colon cancer surveillance. And this is something that's very important to our IBD patients, of course, because of the increased risk of colon cancer in that population. But I think it's very important the way, Pascal, you've really brought to the forefront for all of us how some of the things that we assumed about colon cancer access for our patients for surveillance really has changed a lot of my own thinking on this. So really strong work, and that leadership, not just within Sinai, but throughout the country has been great.
Thank you.
So I'm not wearing blue. I am wearing blue, right? I'm so impressed. So Pascal is wearing blue for the two of us, so I apologize for that, but it is an important month. Pascal, what are some of the ways that our patients, not just with IBD, but members of their family, can be screened to protect them from getting colorectal cancer?
Well, I think the most important thing I think you brought out is there are many ways, right? So we have to think about what ways are comfortable for the patient. We have non-invasive testing, which basically means you can take a stool test in the comforts of your own home, whether it's a fecal immunochemical test known as FIT or a stool DNA test as well. And so those are ways that people can do that without having to have a procedure, which is an invasive test, like a colonoscopy, in which you'd have to come see one of us, come into the endoscopy suite, get a little anesthesia, and for us to actually take a direct look at the colon, the lining of the colon, to make sure that there are no polyps or growths on the lining of that colon, to remove them and ultimately prevent colon cancer.
So really, there are many ways to do this. You don't have to go through this whole invasive test, and it sounds like really the best test is the one that gets done, right?
That's right.
That's the old phrase that I remember hearing from you. Yes, from you.
So, it didn't come from me. I give credit to, Dr. Winnower. I give credit to everyone at Sloan Kettering, my mentors, for really pounding that in. The one that gets done is the most important thing.
So, I guess the next question I have, and I'm trying not to make every IBD Third Thursday about COVID, but it seems to creep in like the virus that it is. It gets into all these unexpected corners. What has been the biggest challenge in getting patients screened, both during the pandemic and prior to this pandemic, and actually going into the future?
So prior to the pandemic, we had the usual barriers to care, such as first and foremost, I call them like personal barriers, fear, embarrassment, obviously not wanting to know what's going on and kind of having that denial piece of it. And so that's always lingering, whether it's pre or post COVID. But I think COVID has brought another curveball to that, and that is access. Right. So a lot of underrepresented patients, especially in the clinic, didn't have access to physicians via telehealth. So telehealth has been a challenge in terms of getting your usual doctor's appointments. And as we were shut down for COVID, that was only the only means for a short amount of time that we had to reach out to our patients. And
Mhm.
so going into the future, telehealth is here to stay. And so having that extra layer of access to our patients, whether it's in person or video, has been a big charge within the GI clinic. And then you have your other barriers, such as your transportation, socioeconomic or financial factors. So all of this and COVID on top of that really strained and widened the disparities gap with patients trying to get care and get screened.
Yeah, so I really agree. That has been both a real blessing to be able to reach out to the patients, but there's only so much that you can do, right? And
Well,
which gets so what are so when you're on telehealth with somebody, you're going to talk about how they're feeling and their symptoms. So what are some of the symptoms that you think are helpful in trying to determine whether or not colon cancer ought to be on your mind and on the patient's mind?
Sure. I think the first thing that people think about with colon cancer is bleeding, right? Are you having any rectal bleeding, whether it looks red, whether it looks maroon or dark colored? The rectal bleeding is probably the number one thing that a lot of patients have in their mind and that I always ask about during every visit. Other more subtle things are change in bowel habits.
Mhm.
We see that patients who come in who usually have had a bowel habit of, let's say, going once a day, and now they're going every 3 or 4 days, and that's been consistent, not just a one and off thing. And so consistent change in bowel habits, unintentional weight loss. So you're not trying to lose weight, but your clothes are fitting looser and you feel as though you're not really taking in as much food. All of those things together are what we call alarm signs or worrisome signs for patients. And then we have, nausea, vomiting, other things that are not just your one off where you had something bad to eat, but that's something that's persistent and that's not related to your normal day to day life. So, all of those symptoms I ask at every single visit with every single one of my patients, just so that if there are anything that we can catch early.
So what can we do then, we physicians? What do you suggest we do better to encourage our patients who might either be on the fence about it or still have apprehension about it? What can we do better to encourage them to obtain their colorectal cancer screening?
That's a great question. I think it's a two-part question. So, physicians for themselves, there are physician barriers related to screening. So, physicians say there's a lack of time to discuss screening with their patients. They say that it's a lack of guidance in terms of what age should you recommend. There's so many different guidelines that it's hard to keep up with that. So, a lack of knowledge, in a
Mhm.
sense. And so once those barriers are down, where physicians know which patients are high risk, which patients need to be screened at what age, then you have to have a conversation with your patient, right? You have to sit them down and say, this is appropriate screening time. Do you have any questions? Do you have any reservations? Right? I always end all of my visits with, do you have any thoughts, questions, or concerns? Because
Mhm.
they may not have a question, but they may have a thought or they may have a concern about what I just discussed. And so I think taking the time to discuss with each of our patients what their personal barriers to screening are is a very intricate piece. And sometimes time can come in to that as a barrier, right? When you're a primary care doctor, for example, and you have to discuss their 5 different chronic medications and 5 different chronic diseases, but prevention always comes last. I think one thing that I've always emphasized is discuss prevention first. Before we delve into the problems that you have, let's try to stop the problems that you may not want to get, which is colorectal cancer, and let's discuss prevention first. So those are the kind of ways that I think can flip the conversation around. and make sure that prevention is at the forefront of everyone's mind before we discuss, trying to treat the diseases later.
So I think for our patients, I want to sort of do maybe a very brief, if you don't mind, because listen, I have access to Dr. Pascal White, so I can just ask you, right? And here you are. So I want to sort of make sure that when some of the patients who might say, well, is it something I need to think about? Because I know there have been some, it used to be 50, 50, 50. Yeah, just 50, just think 50, just think 50. If you're 50, you got to have it done. It was like a rite of passage for all, even as physicians.
Yes.
But there have been some pretty important changes in the guidelines for our Black patients and for patients who are male. Do you want to go into some, and again, just some numbers for some of our patients that might be useful?
Sure. So 45 is the new 50. And so the
Hallelujah.
The American Cancer Society in 2018 came out and said that 45 should be the new age for screening, given the data that was input between the early onset colorectal cancer in younger patients, and figured that 45 was the sweet spot between trying to prevent these early cancers from creeping in, and obviously balancing any risks and obviously added cost to doing lots of procedures. So 45, 45, 45 is what patients should know. And ultimately, for our African American patients, the American College of Gastroenterology back in 2009 and updated in 2017, their clinical guideline for high-risk patients, African Americans, to get it screened at 45. And so 45 has been the age for African Americans for quite a while now. And now that it's 45 for everybody, that can kind of permeate through the population. Everyone will know 45 for all. So that's one big thing that we're championing now that it's Colorectal Cancer Awareness Month.
Excellent. And also know your family history. These are hard things to bring up at the dinner table, but these are average risk patients, but if they have a family history, know the age when it happened. That obviously gets lost in some of these clinic visits.
That's right.
So Pascal, let's say I'm a patient and I'm not quite convinced yet. What advice would you give to our listening patients? And these are patients who are either average risk or even patients with IBD who are reluctant to pursue colorectal cancer screening. What would you say to those patients who are hesitant?
I would say that the best gift to health is prevention. Colorectal cancer is preventable, it's treatable, it's beatable. If you have reservations about the test, talk to your doctor and get your questions answered. And otherwise, we're here to support you. We don't want to treat colorectal cancer anymore. We want it gone, and we have means for it to end. And so please, we implore you to ask all the questions you can, get the screening test that you feel the most comfortable with.
Yeah, I agree. It's better than it used to be.
Yeah.
I know our older colleagues would describe, the role of the gastroenterologist was to do the digital rectal exam and then console the family, right? Those were the old days. We don't do that anymore. So I think the idea here is, I completely agree and want to echo what Dr. White just said. If you're on the fence about it, ask some more questions. It is heartbreaking for us to have to treat colorectal cancer in this era. The procedures are so much better. The screening tests are so much more precise. This is something we can change. And we've made progress. We know now that these procedures and these screening tests save lives and prevent illness. So excellent. Well, listen, Pascal, we got to do this again.
I hope you do. Thank you so much. This was fun.
And I look forward to seeing you in the endoscopy unit and around the IBD Center. So thank you for joining us.
Thank you so much.
This is Dr. James Marion signing off for another third Thursday from the Susan and Leonard Feinstein Inflammatory Bowel Disease Center here at Mount Sinai Medical Center. I'd like to thank you for joining me and my guest, Dr. Pascal White, as we discussed colorectal cancer screening during Colorectal Cancer Month. Thank you, Pascal, and thank you all for joining us.